Thank you, Dr. Jain-Spangler, for talking to us about general surgery and fellowship training in the U.S. You're a recent graduate, and we appreciate your perspective. Can you tell the audience a bit about your career stage?
Sure, Chris. Thank you for having me. It's my pleasure. I finished my fellowship in minimally invasive and bariatric surgery at Duke in July, and for a few months while I was interviewing, did some locums general surgery work. Following that, one of the places that I was actually working was very interested in bringing me on as their bariatric surgeon. So for about 6 months now, I'm currently doing both general surgery at one location for half the week and also doing outreach and bariatric surgery for the other part of the week.
Okay, great. And so you graduated about 7, 8 months ago, or finished up?
Yes.
Okay. And so, what's your perspective on training in fellowship and in general surgery training? Actually, why don't we start with general surgery training? What about the U.S. system seems to be functioning well, and what about the U.S. system do you think could undergo some overhaul?
Sure. I think general surgery training has changed pretty significantly in the last 10 years. When I started, I feel like it was a different thing than what it is now. So the strengths and weaknesses, I think, have changed. In my experience and my perspective, I've found that I did leave my general surgery training feeling very well prepared to become a general surgeon. In fact, I started my fellowship. We were credentialed as attending surgeons and started taking general surgery call right away. I'm not sure if that's still the case. More and more residents that I talk to are feeling a lot less prepared for a solo general surgery situation.
What do you think accounts for that? It's probably multifactorial,
It
but
is
yeah.
multifactorial, and I hate to say it because I know, we blame everything on work hours, but I feel like limiting work hours hasn't just limited issues arising from being on call too long or that kind of thing, but it's also limited somebody's ability to be accountable and responsible and maybe participate quite as much in patient care, including going to the operating room and being able to follow through with an entire scenario of patient care. A lot of times I feel like towards the end of my residency, especially because I was limited, things seemed a lot choppier as far as being able to actually continue following a patient and participate in all of their care.
Mm-hmm.
So I do think that that has affected it. I think also, training is so different around the US depending on what kind of program you're in. I was very lucky. The city that I trained in Richmond, Virginia, was the center happened to have an extreme variety of cases. And so by the time I was finished, I felt like I had seen most everything, done most everything. And I don't know that that's the case everywhere or at every program. So I think that maybe that accounts for some of it as well.
Okay. And do you think some of that lack of breadth comes from just what they get locally, or is it interference of fellowship programs?
Yeah, so I think a lot of it does depend on where you are. And now that I am practicing part of the week in a very rural local community where there's nothing around for a good distance. I, of course, being the young general surgeon, it seems like every night that I'm on call, I'm getting these bizarre cases because there's nothing else out there. Unfortunately, some training programs, I think, are being affected by not only the fact that there are fellows, but also the fact that everything is becoming so specialized that there is a center for everything. There is the place to go to for, and it doesn't matter what you fill in the blank. So I think that that's what we're seeing with a lot of the numbers.
Right, right. So over specialization, sort of in one area, and
Right.
limiting the breadth for the people's training there. Right.
Exactly. I mean, it's almost like there's specialization in every area. There's
Mm.
nothing left that isn't a specialty for someone.
Mm-hmm. And what about fellowship training? Does it suffer from some of the same problems, or is that a different kettle of fish? It probably
I think
depends a lot on where
I
you
think
are
it
as well.
depends on the fellowship.
Mm-hmm.
Um, because so my fellowship was minimally invasive and bariatric surgery. Yeah, sure, bariatric surgery is pretty limited, but minimally invasive surgery seems to extend as far as you want it to. People are doing more and more and more things. And the nice thing is that you can't just do minimally invasive surgery without being an excellent open surgeon. So I did not feel like I was being put into a box in my fellowship. But I think as we get, into the colorectal and then the subspecialty of the colorectal and then people are coming to see you for one thing, it becomes more and more difficult to get out of that. So as we look to specialize ourselves to have a niche for patients, at the same time we're kind of moving away from being general surgeons.
Right, right. What do you think about earlier differentiation for surgeons who know that they want to go into a subspecialty training program,
So the vascular, the thoracic, that kind of thing,
or even minimally invasive?
or even
I,
minimally
I,
invasive. I don't think so. I I benefited from having. I did 7 years of residency, and I definitely benefited from having all 7 years of my residency, trauma, surg-onc, transplant, all of it. I think definitely benefited me as a minimally invasive surgeon. That being said, the breadth of what I do is not necessarily the breadth of what a vascular surgeon is going to do or a thoracic surgeon is going to do. Some would argue what is a thoracic surgeon really benefiting from spending months on a transplant rotation.
right.
And I think there are valid arguments to both sides. I think what we need to determine is what is the amount of time that a vascular surgeon needs to be in the belly to be able to do a AAA open. How much time does somebody who's specializing need to spend in general surgery training? Does it need to be 5 years? Probably not. So I think that before we rule it in or rule it out or continue down that road, we definitely need to look. I don't know that I've seen any studies or anybody looking at the amount of time it takes to be comfortable with certain skills
Yeah.
that each specialization is going to use.
Or how about then instead of the amount of time, the number of cases? In other
Right,
words, a
right. What is the
competency
learning curve?
based.
Definitely.
Okay. Do you think a shift toward competency based advancement in uh, general surgery training
Yes,
is
with a
a good
caveat.
move? Hmm.
I do. I think that, skills are skills and we have to be able to do certain things. Clinical judgment, thinking on your feet, that doesn't necessarily come with competency, quote unquote, with a simulator or any of that. So I think um, skills testing, competency-based evaluation will be useful and maybe will help people decide the correct path for them, but not necessarily is the end all be all.
Yeah. Okay. Now, if you could change a couple of things about if you were in charge of a program right now, would there be one or two things you could point at and say, let's end the work hour restrictions. Let's start this. Let's start that.
So I found in my training, I really benefited from having people that I looked at as mentors and being able to follow them through my residency. There were certain people that I gravitated towards, that I thought like, or that I wanted to be like because I respected them or admired them for whatever it was. Um, there was something about them as a surgeon that I liked. And I felt that towards the end of my residency, because of the structure, there was less of a mentor attitude and more of a you have to do all of these certain things to finish. And so maybe it goes along with some of that earlier differentiation into specialty training. Maybe it's just the ability to have a little bit more freedom in residency. I would have really liked that. I would have loved to have done a rotation in radiology, spent some time with the orthopedic surgeons, that kind of thing. And if you know that you're going to be a rural general surgeon, you need to know those things. Today, somebody asked me, can I do OBGYN if need be? They had something in the ER that they thought they might need me on. And I'm lucky. I've scrubbed on several OB cases and I'm comfortable with that, but I think that we're getting further and further away from that. So
Right.
I kind of do wish there was a little bit more freedom in our training and being able to not just check boxes and fill out numbers of what I've done, but maybe have I done the things pertinent to what I want to do in the future.
Yeah.
So that for me, that's one thing.
But I guess the requirements of the RRC or the ACGME or something sort of pushes everybody to the same standard instead of preparing them for what they might be planning to do.
Right.
Mm-hmm.
And unfortunately, there is a lack of general surgeons in the United States, but we're not really creating an atmosphere that makes somebody want to be, and
Yeah.
people say it all the time, just, oh, they're just a general surgeon.
Right.
But sometimes the most
Even the status is going down.
exactly, exactly. Oh,
Yeah.
they're just a general surgeon. They're not specialty trained. They didn't do a fellowship. But
Mm-hmm.
sometimes that's the most difficult job there is. I mean, it is
Sure.
far harder for me right now sometimes to fulfill my general surgeon role than it is to fulfill my bariatric surgeon role
Mm-hmm.
because I'm comfortable in that one little world. But the general surgery world, I mean, you can get called about anything at any time, and it's very exciting and fun, but you do have to feel confident
Right.
in being able to do all those things.
Right. That takes a lot of time to get that sort of breadth of confidence
Right.
across the whole general surgery field. Yeah. Um, so you trained in advanced laparoscopic. You did some robotic training as well, right?
Correct.
So what's your sense for how fellowship training in advanced laparoscopy and robotics is moving? Do you think there's a good I don't know how to say credentialing or standardization across programs, certain skills that everybody who is advanced lap trained is going to end up with, or is it all over the map?
I think it's a little bit all over the map. Some of it is affected by things like colorectal fellowships, things like that. So who's doing the colon cases? Who's doing the Nissens? Is there a esophageal surgeon? Or, in some places, the bariatric surgeons are doing some of the upper foregut GI tract stuff, and it kind of is all over the place as far as that is concerned.
Mm-hmm.
So I think your idea of what advanced laparoscopy is pretty varied. Just saying, and I've talked to several general surgeons who are somewhat offended by saying, oh, I'm an advanced laparoscopic surgeon because in some places, just the general surgeon, quote unquote, is the advanced laparoscopist. So I think you
Right.
do have to be careful in calling yourself that and thinking about what it is. I do think some of what the skills that are incorporated when you use that term are I'm comfortable doing intracorporeal suturing. I'm comfortable doing an entire abdominal dissection laparoscopically, as far as colon is concerned.
Mm-hmm.
I don't know that this is what everybody's opinion of it is, but to me, that's what it means. When I started my fellowship and when I finished my fellowship, there are certain skills that I could have never done as a resident that I
Mm-hmm.
definitely learned as a fellow.
Mm-hmm.
Some of that came with working, I had 6 different bosses at Duke. So 6 different people do things 6 completely different ways, which is nice to see and learn from. But, more advanced use of your thermal devices, that kind of thing, I think comes with experience and with fellowship.
Mm-hmm. Is there an accrediting body of some sort that looks at programs and says, yes, you can call yourself an advanced laparoscopic
For
training program?
bariatrics, there are numbers, but
Mm-hmm.
not that I'm aware of as far as, minimally invasive or laparoscopic numbers are concerned. Now, the only time numbers really come into play is when you're getting credentialed for something. So, at the end of my fellowship, I got credentialed for the Da Vinci robot credentialing as well as a single site incision platform for
Mm-hmm.
the actual Da Vinci platform. Each of those required numbers. And so that's when it came into play. But there's nobody's testing your skills. Nobody's writing down what you've done,
Mm-hmm.
except when it comes to that.
Mm-hmm. Mm-hmm. Okay. So what else comes to mind that was interesting or important in your experience as a recent graduate?
Well, I mean, talking a little bit about the robot, I have to say, I love the robot. I don't think there's any surgeon that doesn't like
Mm-hmm.
operating on the robot. It's fun. It's neat. It is very intuitive. So I think it will be interesting to see where that goes.
Okay. Yeah, I'd like to actually catch you with a second interview if I could about the robot.
Sure, that'd be
Okay.
great. Especially because I'm starting to do some some robotic bariatric surgeries, and we did them a lot in my training, and it's interesting to see where that will end up. I'm not sure where it will end up, if it will end up anywhere, but it's kind of with every specialty. I think we're figuring out where the robot is going, so that would be interesting to talk about. Otherwise, I think the thing I loved about my fellowship was that it finally, because mine is not a work hour regulated fellowship, I finally figured out that I, as a human being and as a good surgeon, am able to take the highs and take the lows and take the long hours and the short hours. And for once, I finally felt like I was able to hold my own. And that, to me, was one of the most important things of my fellowship, was learning how to be a good doctor, how to know when you're tired, how to know when you need help, how to know, what your boundaries are, and how to be confident in yourself and do what you've been trained to do.
Oh, so that's interesting that's getting pushed into fellowship now because of work hour restrictions. That's an interesting point.
I mean, it's when you look, even let's say there are some places, there are stories about it back in the day at the VA, when residents would operate by themselves, and that doesn't happen anymore. Right. Everything is regulated, and there are good points to that, and there are definitely maybe some things in maturation that are being pushed further back because of that. Did
you see a shift in autonomy in your years? In other words...
Yes.
Okay, you did.
Absolutely.
Okay, so just in that... So in 10 years then, in the last 10 years, it's changed substantially in your view. Okay.
Yeah.
Well, thanks so much for your input. I think those are some important topics. I appreciate your time.
Thank you.
Thanks.
It's great
talking.
Talk
again soon.
Bye.
Bye-bye. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.